Okay, so we're going to jump into our reporting back now. All right, come on up, Cheryl Ann. I was also facilitating a group. We were a group looking at the older person standard set developed by ICHOM. As a whole, we found the overall approach to be a really important one. We're impressed by the amount of work that's been done so far. Would love to see more population groups outside of disease-specific population groups being developed, because that broader look at prevention and promotion is really important. We did have a big kind of question that we don't necessarily expect to be answered here today that came up as part of our conversations, which was just that. So because we were looking at older people, and it's more of a prevention and promotion viewpoint, but we wondered about diagnoses and comorbidities. So if this individual, a given individual, has been diagnosed with one or more conditions, would their care team be using this older person sort of prevention and promotion set of outcomes, as well as the disease-specific outcomes that they've been diagnosed with? And how would that all work together, and how would those care teams work together? So those were kind of some of the big questions we asked ourselves. Overall, we had a few gaps and improvements that we identified, without being able to go into detail of what these specific outcomes are, how they're defined, and all that good stuff. So some gaps, some specific to the determinants of health, lodging for older people. Do they have it? Is it adequate, et cetera? Also enough funding to make ends meet. We know that many older people are living with not enough means, and that's increasing. So it's an important question to ask. A gap around mobility. They don't seem to be asking about mobility, both their own individual mobility and ability to get around, frailties there, so maybe that's their proxy, but also their ability to be mobile in their community and to be able to get to different settings and different groups and that sort of thing. We saw a gap in nutrition and looking at nutrition. Also, under symptoms and quality of life, sleep. So they're using a survey that includes activities of life, but it doesn't. The limitation in that survey, according to Wikipedia, is that sleep's not included. So we thought that was a gap. Improvements that we saw relate to under quality of death. They use place of death as the outcome measure. We didn't think that that's good enough, that choices such as how, when, and with whom one dies are also important. Improvements, they look at participation in decision-making. We don't know, could people game the system depending on what that outcome measure looks like? So are you ensuring that there's the supports necessary, the full information being given appropriately, and enough time for someone to participate and make decisions? Or are there ways for people to kind of game the system by giving two choices in 2 minutes and say, yep, they participated and they're making decisions? And then finally, room for improvement. They look at time spent in hospital, but then we were asking ourselves conversely, are they receiving the needed care in other settings, whether that's at home or community health centers or other types of places? So that was our feedback.
Thank you. Ron and I are going to talk about the chronic disease group that we had a look at, and very similar to yourself in terms of chronic disease. What we found missing is that by having a group with chronic disease, there were multiple comorbidities. So people were trying to move from sheet to sheet, and that didn't seem to be addressed. And it was also, how do you create we kept seeing the family health team emerging all of the time as we went through it. We thought the efforts were really good to have the proms, but we questioned whether in fact patients were really involved in identifying what the issues were for them. The quality of health issues that you just identified, we also saw missing was nutrition throughout. In some of the areas, some of the proms, we saw mental health issues that weren't addressed, and they weren't addressed in the quality of life issues. So what was there was good, but there were tons of gaps. So we thought you really have to revisit patient groups again, get their input on what the quality of life issues are for them and what's missing for them. Some of the other ones had very specific things missing in them that weren't addressed, and we wondered maybe some of these proms were developed some time ago and treatment has changed and the life has changed for people. We saw caregivers as a huge issue, so when you raised about mobility issues, it was the impact on caregivers having to go to multiple appointments and then that breeding diverse of dynamics within the family group itself. Ron, more particular issues?
No, I think you covered most of it. It was just interesting to note, how many people felt that the PROMs that we looked at felt siloed when it came to chronic disease and how important it was. And John, you said it around recognizing that people may, for example, have an autoimmune disorder which leads to a lot of other health-related problems, and how you need to really kind of reimagine the PROMs so that you can cover off complex chronic health conditions. So they felt somewhat simplified. There were a number of general gaps and comments, particularly with regard to depression and mental health issues related to many, many conditions. And they were listed on some of the PROMs, but on others they were not. That's a general comment. Also, not always listed were costs related to treatment, particularly to rehabilitation and occupational therapy and all that kind of thing, as well as to diet. For example, on the diabetes sheet, there was no real reference to learning more about aspects of nutrition. People also raised some issues that I think are specific to the Canadian healthcare system that they found frustrating, that they wanted to be part of PROMs relating to wait times and also slow response times between and among practitioners when results had to be sent off from one specialist to another in kind of a chain, and the importance for care to be considered in a more holistic fashion, as well as, generally speaking, a lack of mention of screening for prevention or the worsening of given conditions. Yeah, I think that's about it.
I just wanted to, I forgot to add a major thing that we saw a gap for was there didn't seem to be any rehabilitation within any of the PROMs. Didn't matter what the chronic disease group was.
So I'm going to report back on mental health. So one of the pretty problematic pieces of that was missing for this population is even though we're talking about patient-centric, the language is very medical-based, medical model-based. And it sounds like it's a tool for the system. So you don't actually hear the voice of the community in the tool itself. And that could just, be a language lost in translation problem. But for us, it went a bit deeper. In particular, how it talks about recovery. It says things like time to recovery or like symptom abatement. But what we know about recovery is that it's an individualized and ongoing process. So to label it like this is very problematic because it gives you an idea of, where that's coming from or how it's being looked at, which is not realistic for the population that we're looking at and for many chronic illnesses, I would imagine. So when we talked about what's missing, one thing that we noticed was this may fall under social functioning, but it wasn't specified. But things like feelings of belonging and sense of community that can often be very relevant in anxiety and depression in particular. So we suspect that might be part of the measurement, but it's not clear to us. And another big thing that seems to be missing is that the focus is on social expectations, so things like work functioning, social functioning. Again, it sounds very much like it's system focused. What seems to be missing there for us is there's no indication of individual choice. And who created the measurement tool? So though the PROMs may be based on measurements by the people who are affected by the illnesses, who created the measurement tools that they're using to gauge progress? And we would hope that patients could be involved in kind of what we're doing to measure those things as well. We noticed the big gap about social determinants of health, so we don't see anything about housing, financial security, food security. These are all obviously very relevant to the population that we're looking at. When we talk about strength, John said something like, "What was there was good." So even if we go beyond the language, what did seem to be included were important and resonated with what we know about the mental health community. One of the things that I think it was unclear to us is when they talk about the treatments that are included, we weren't sure if those were concurrent or if they were one over the other. So we're not exactly sure what people are being measured on in terms of what type of intervention they're getting. So what can be improved? The great question. So language is a big one. Especially around recovery. I think having patients actually look at that and retune how it's being talked about is really important. And obviously the social determinants, like we mentioned, and also making it clear about how these measurements are being applied. Like, is it based on the person's individual goals or choices, or is it based on kind of the top-down system and what we think would be appropriate? So those were some of the feedback that we had.
So now we get down to the point where I think we all picked up a lot of the differences and gaps, but what we started to do is we took a look at the cancers that we were looking at, prostate, lung, breast, noting that there was nothing for blood cancers, nothing, but that's okay, because there were several blood cancer people. But we started to look at the consistency in the language, and what was interesting was it wasn't. There was no consistency. And we kind of said right away, hey, you know what, if you have to build proms like this, you need to figure out why is there a lack of consistency in the wording you're using, like when you say quality of death or quality of life, or why is it not always defined the same across all the spectrums of cancers? And if it can be made to be consistent, it needs to be homogenized across all of them. We feel that proms are different along the continuum of the disease cycle, not using the word journey here. These proms are not based on a patient segment, but we felt that they were more based on the disease type. So that led us into a whole conversation where we said, you know what, these really look like they're not proms, but they're like standard sets for things that you want to achieve for these particular diseases. So we had some problem with that. As we learn more about diseases and treatments, proms need to be retested because they're really actually a living document. They need to be accompanied through partnerships with patient groups to collect real world evidence, meaningful. And at this point in time, Martine and Cheryl think that there should be some sort of database, but I'm not using the word registry here. And then we were just going back to the example that we saw this morning that she was talking about the cystic fibrosis patients. Well, you know, now that there is so many breakthrough treatments and patients can expect to live longer, now you're asking them things more in the registry database world. Do you want to go for, are you going to go for a university degree now? Are you going to be thinking about having children, planning a family? Things you couldn't ask before. And to that point, we came up and said, Kathy mentioned it, I feel the same, Martine feels the same. We have so many innovative treatments now for blood cancer patients. It would be awesome to do proms right now for these diseases because we've got the critical base of patients that have the information that you need in order to build these proms. We also think that the proms, we need to put pressure on making sure that proms are part of clinical trials, so that once a patient has been cleared and approved and can get on the clinical trial, right at that point in time, you sit down and you develop proms. So they're not being used early enough in the clinical trial phase. And we think that they could be, clinical trial proms can be put into at the secondary endpoint in the clinical trial phase. And if you just think about this would certainly add important input towards the HTA and determining funding issues, because really, what are people coming back and asking the patient groups? They're asking us to put in proms, outcomes, what do patients want in order to determine if you want funding issues. And imagine a world where that would save a lot of money in healthcare if you came out with that right away. And you would know already who is your segment of patients that are going to really benefit from that treatment or not. PROMs need to be collected across the country and shared, and patient groups need to have access to that information so that we can truly validate that it's there. And you're right, we didn't feel a patient voice in many of those PROMs, and it was interesting because they're supposed to be like patient-centric. That's it.
Wow. Fabulous work. And I don't see Jerry or Alex, unfortunately, so we're not able to hear back from the observer groups, but we'll take a look at their notes, and if there's anything new or exciting, we will bring it back to you tomorrow morning. For those of you who might want to go a bit deeper on any of the standard sets you were looking at, just a quick reference, you just quickly Google ICHOM standard sets tonight or tomorrow or whenever you feel like doing this, and you'll find them all online very easily. And what you can do is there's something called the reference guide for each one of them, and you don't need to pay for any of these. You just have to give them information, your contact info, and then it will give you the PDF. And in the reference guide, for those who are so inclined, there include things like definitions for each of the measures that are being proposed, the actual instruments that are being used to collect the data, the time points that the data is being collected, what the associated risk factors are. There's a lot more detail in those guides if you're so inclined. So now we're going to wrap up. And, yeah. Dive into the guide, and yeah, exactly. Absolutely, yeah. So just to quickly wrap up, it's been a long day, and I want to thank all of you for all of the travel, for being such engaged participants with such an enormous amount of information and sharing and conversation. I hope that you found the day valuable. For myself, I at a very high level, I would say that across all of these different talks, the theme of patients, caregivers, as partners in the health system and all the different aspects of it, not just patient-centered or a stakeholder, but moving towards more and more of that empowerment side, that partnership side of the continuum has been a theme throughout the day. And this, I want to just remind us of that incredible, that the ability for patients, and this summit being a platform just for the networking and the ideas dissemination to influence, to use someone else's term, a revolution towards, we're talking about value-based healthcare, but basically, systems that are putting patients at the center of the system and as partners in getting there, right? The excitement that I think an approach like value-based healthcare provides, in that it's giving everybody, patients, caregivers, providers, the different system players, whether they're private or public payers, HTA, et cetera, it's giving them opportunities to find win-win situations. Everyone often are trying to do their best. I would say most people, are in the work that they're doing for positive reasons. We have had a system that's so fragmented and has become so dysfunctional over time that it creates a lot of siloing, as we know, and a lot of competition that feels negative sum, and it is oftentimes. And I think the real value of looking at the outcomes that are of importance to patients and then assessing what are the costs across the entire continuum of care to achieve those starts to bring all of these different players together to look and see where there are huge opportunities to work and collaborate and win together with patients as partners at the center. And I would say that Stacey's presentation talking about the positive impacts on patients, on providers, and on the system itself, some of that early evidence coming out of value-based healthcare starts to show that that is what this approach is doing. So thanks to all of you. See you in the morning, bright and early. Again, cabs are going, so meet Chantel at the registration desk. And at 7:15 tomorrow morning, if you're at the hotel, meet in the lobby, and we'll share cabs back. Have a great evening, everyone.